All right, so we're here on a nice day in July of 2022 with Dr. Jack Farricy, obstetrician gynecologist, and we're going to talk about your career. So, what brought you into the career of medicine? When did you decide you wanted to become a doctor?
Probably in grammar school, late grammar school. I just always wanted to, be a physician and never changed my mind.
And do you recall what turned you on to that at all? Were there family members? Were there any sort of role models that you had?
Well, my parents had a good friend that lived downstairs where I grew up who was an obstetrician, which probably should have turned me off to the career when I saw how going out all hours of the day and night. But he was
Mhm.
actually a good influence.
And so when you graduated from high school, where did you go to college?
Boston College, 69,
And you majored in,
biology.
okay. And then from there moved on to
Georgetown Medical School.
Georgetown Medical School. And you entered medical school in what year?
Entered in 69, graduated 73.
73. Okay. And how big was your class at Georgetown?
About 120.
Wow. And did students drop out at those times, or was everybody who was there on year one there on year four?
Pretty much everybody stayed. We picked
Yeah.
up a couple of stragglers.
Okay. And were there any women in your medical school class?
Several, yeah.
Hmm. And how much did it cost for tuition at Georgetown in those days?
2250.
Okay. And your sense was that that was attainable even for the average person?
Yeah, it's just like college. And those days, you could save that doing a summer job,
Hmm.
you
So that
know.
made it accessible.
Right.
Good. And anything about medical school that sticks out with you, particularly fond or distressing memories?
No, mostly fun. People I met and made some good friends. And
Yeah. Okay. And then you decided to go into OBGYN.
right.
And what moved you to that decision?
Well, in those days, there was family practice was just a budding specialty. And OB was sort of the last specialty where you had to dabble in a little bit of everything: surgery, endocrine medicine, pediatrics, stuff like that. I was just attracted
Hmm.
to that aspect of it.
Yeah, very general. Um, and you did your residency where?
At Georgetown as well.
Okay. And how many people were at each level there?
4 to 5.
Okay. Any women in the program at that time?
No, none.
Okay. Yeah. And so that's an area in obstetrics and gynecology that has really changed over the years.
Right.
Back up until the 70s or so, women were just moving into medical school, and during that time, there was a significant shift um, towards obstetrics and gynecology for those women who graduated. Any memories about your residency? Was it brutal? Was it doable? Did you
It
emerge
was hard
burned
work,
out?
but
Or,
you just sort of grin and bear it. Everybody was working just as hard. And
yeah.
you just came
Were
to
you
accept
married?
that as the norm.
Were you married at that time?
After my first year, yeah.
Uh-huh. And during your residency, did you have any children?
Yeah, two.
Okay. And how was having a family and being a resident? How'd that work out for you and your wife?
Well, you were away a lot, but my wife was a nurse, so she sort of knew the drill. And, we just traded off with friends about watching kids and stuff like that.
Hmm. Hmm. And any particular cases or any particular attendings that stick out in your mind regarding your residency? Any stories?
One case of a lady with a ruptured uterus from trauma that the fetus survived, which I thought was a miracle at the time.
Yeah, remarkable. And any attendings that stick out in your mind at all?
Yeah, 3 or 4 of them. There was a Dr. John Gleason, who was sort of the unsung hero of the residency program. He's the one that really
Hmm.
taught us all surgery. made it, just an average guy in private practice, but he really had a commitment to surgery, but to teaching.
Mm,
So he was pretty special.
yeah, great. And so you're finishing your residency and you're deciding where to practice. What'd you go through then? How'd you make your choices?
Well, I pretty much just looked in Eastern Mass. I had an offer down there, but our family is from here and sort of thought that if I came back and didn't like it, I could always go back and get a job in Washington. But if I
Yeah.
didn't, if I stayed there right off the bat, I'd never know whether I would have been happier back here. As it was, we're happy
Yeah.
we moved back to New England.
Hmm. Hmm. And how did you locate a practice? How did that go as far as coming to Worcester or a specific practice?
The guy that I eventually went in with had a loose affiliation with Georgetown and a couple of docs there. So somebody gave me his name and also a couple of other people in New England, but I hit it off so well with him that I just took the job. And
Uh-huh. And so you would have, this would have been around 77 or so?
yeah,
Okay. And at that time, you joined one other doctor in practice. He was in
correct.
solo practice?
Yeah.
Okay. And did you have any reservations about that? Was the advice you were getting as you graduated from Georgetown residency, were they saying that practice was changing and you should go in one direction or
And I should go what?
in one direction or another? I mean, were they pointing you and saying,
No, no.
solo practice is gone or whatever? Okay. I bring that up only because I finished a couple years after you and I did my residency in Cleveland, and the general tenor of things
Yeah.
was that group practice and multi-specialty groups were the future, and private practice and especially solo practice was something that was going to fade out. So it's interesting we got different advice
Yeah.
as we rounded the bend there. So you joined Dr. Willett in practice, and what hospital did you practice at?
St. Vincent in Worcester.
Yeah. How was that?
Oh, back then it was great. It was very nice. At least in our department, in those days, the doctors got along with the nurses. We used to, have retirement parties together and have Christmas parties together and stuff like that. It was a great place to work.
Yeah, yeah, a
Everybody
lot of
looked out for each
camaraderie.
other.
Yeah, yeah, definitely. And again, when you were in practice, was Dr. Willett doing OB? How were you covering yourself at night?
Well, he was 59 when I joined him, and he said, I want to do this for a year or two and then work for you and not do OB. So we gave up OB after a year or two, and then I started covering with a couple of other people in a different practice.
Hmm. Okay. And so at that point, you'd be on call every 2 or 3 nights in that ballpark.
Right. Yep. Every
Roughly
third.
how many deliveries? In After your practice was established, roughly how many deliveries were you doing per year?
Probably about 200.
Okay. And how was family life in those days? Were you
It was good. We
did
were
you
making
have
money for the first time in our lives, so we had a house and
uh-huh.
yeah. I
Okay.
mean, it still had the call, still was out a lot, but we made do.
Hmm. Hmm. And comparing, for example, the beginning of your residency with the beginning of your practice and then more contemporary times. Think about the diseases you were seeing and where you've seen, such the greatest amount of change. What sorts of things impress you as far as progress regarding your ability to care for your patients?
Probably for me, it was the advent of hysteroscopy because that really changed what you had to offer somebody. You were treating a lot of the same old diseases, but in a lot more less invasive way and time
Hmm.
consuming way for your patients.
And so you really trained at a time when laparoscopy was just coming in. So you would have been
Just do,
among
we
the
just,
early adopters to that.
yeah, we,
And in those days, it was basically tubal ligation and diagnostic laparoscopy.
right, exactly,
You'd look in, or you would do a tubal ligation.
right.
And how did you handle that at St. V's? What did you also
Well,
go to another hospital?
yeah, well, I went to UMass at first, and then eventually when they opened the surgery center, I did them there.
Sure. And as far as surgical techniques, anything interesting changes occurred during your career
Well,
besides
again,
the
the advent of,
oscopies?
yeah, uh,
Yeah,
the advent of hysteroscopy and
yeah,
um, I suppose I never got into it. I suppose the robots are the big thing now,
uh-huh.
the robotic
Okay,
hysterectomies and that stuff.
yeah, yeah, okay. And as far as dealing with what today is subspecialty work, so when you started in your career,
Hmm.
was there an oncologist in Worcester?
There was one.
Okay, okay. And so if you had a cancer case, how would you typically manage it?
Well, it would depend. I mean, way back when I started, the oncologist, I think, didn't get established as an oncologist because he went into practice as a regular OBGYN. He didn't establish himself as an oncologist for a few years, but we used to do ovarian cancer and node dissections and all that stuff. But of course, over
Would
the
the
years,
oncologist work with you, or would you refer them to him, or would you do the case completely yourself?
usually do the case completely yourself. And then over the years, as he got more established, he'd either collaborate or would refer to him.
Okay. And would he come over to St. Pete's?
Not in those early days, no.
Okay. All right. And with regard to obstetrics, was there a perinatologist in Worcester at that time when you started?
A self-styled one. It
Okay.
was a pediatrician that had, in those days, just taken some extra courses and called himself a perinatologist, but not a formally trained one like we got in the 80s.
Okay. And high risk OB cases, would you manage them yourself? Would you transfer them? How did that go?
In those days, we usually managed them ourselves, but then over the years, uh, ACOG developed guidelines for what we should be taking care of and what we should be referring.
Yeah.
So it just gradually got to a period of, as the years went on, you do more referrals.
Hmm. And uh, would you
Maternal
ever
fetal
bring a
medicine, by
case
the
up?
way, maternal fetal
Yeah.
medicine was just new on the block then anyway.
Yeah.
Memorial just had one.
Right. And that was Dr. Karen Green. And would
Right.
she come over to St. V's to
Not in
see
those days,
cases with
no.
you?
No.
Okay. And with regard to infertility, was there an infertility subspecialist in Worcester at that time?
No, I used a guy in Framingham.
Hmm. Okay. And so mostly you were taking care of the cases yourself at that point
Right.
and referring off to Framingham when you needed to. And these were the days where in vitro fertilization was very early in the curve.
Oh, yeah.
Um, and the technology was a lot different. It was, especially early in your career, was before using lasers and laparoscopies or more of
Yeah.
the operative laparoscopies that came on later in
Right.
your career. And uh, and how would you treat someone with a urinary problem, so stress incontinence? What were the treatments of choice in those days?
Well, with the Marshall Marchetti Krantz operation was very familiar, very popular for
Sure.
anterior repairs for cystocele with incontinence.
Yeah. Okay. And in those days, what when you did a hysterectomy, were you commonly doing vaginal hysterectomies,
Yep,
or were they mostly abdominal?
mostly vaginal.
Yeah. And what sort of indications for hysterectomies in those days?
Symptomatic prolapse, and then the other usual things, menorrhagia. And I did a lot of, personally did a lot of vaginal hist because Dr. Willett had that demographic. He had delivered these
Hmm.
ladies 25 years ago, and now they're seeing them in their 40s, 50s, and 60s. And he really had respected his attitude. He says, I'm not going to do this forever. I want to turn my patients over to somebody who I think is going to take good care of them. So from day
Hmm.
one, I did all the surgery. He assisted me.
Wow.
But of course, he said, put that there, cut that. I mean, I learned the first 2 years of practice. I learned a ton from him.
Sure. Excellent. And uh, did you have indications as far as fibroids go when they got to a certain size? You'd recommend a hysterectomy.
12 to
Does that
14 weeks.
okay? And over the years, did that change at all, or did it
Oh
stay
yeah,
about the same?
no, not at all. The old philosophy was that when you got to about 14 weeks, you couldn't tell that you might be missing an ovarian tumor. Now, of
Hmm.
course, by today's standards, the size is when the lady isn't happy with her dress size anymore.
Yeah.
Outside of a pain or bleeding and stuff like that, they don't really
Uh-huh.
because the ultrasound was so accurate these days. They say, oh, that's a fibroid, that's cancer.
Yeah. And also they would the guidelines I had in those days were that once you hit 12 to 14 week size, you might get some hydroureter as a
Yeah,
result, and that was another caution they had, but somehow that didn't stand the test of time, and these days certainly
yeah.
the indications are a lot different. Um, and what about abnormal pap smears? Were there instances where you'd recommend a hysterectomy in those cases?
Uh, yeah, if somebody would come in and say, I have a carcinoma in situ and I want my tubes tied, we'd say, well,
Yeah,
just get the whole thing done, and that way you don't have to worry about it coming back in the future. Or we would do them occasionally for uh, uh, recurrent dysplasia
hmm
if somebody didn't
hmm
want to have any more kids.
right. And again, in those days, back in the 80s and the like, uh, typically, how many patients would you see in a day? What sorts of problems would you see? What was your mix of OB and GYN?
Probably 50-50, see about 20 a day, and half of them would be new GYN patients or yearly checkups, and the other ones would be just repeat OBs.
Sure. And so we went through a phase where you joined Dr. Willett. He was an excellent mentor with regard to learning more and advancing your skills. Yet the surgical scene changed quite a bit.
Oh, yeah.
Protocols changed quite a bit. How did you keep up, and what challenges did you run into with regard to learning the new things that occurred during your career?
Well, the ablations and hysteroscopy in general was totally new. So I mentored with somebody over UMass to get, in those days it was see one, do one, learn one. Um, and
Hmm.
then with the, as years went on, rather than say, well, okay, I can do this. Well, no, now you got to prove you can do it. I want a letter from that guy saying that you've done enough that you're on your own.
Hmm. And the uh, was the education readily available for the skills that you wanted to learn? Uh, was it easy?
It was.
Okay,
I never had any trouble.
okay. And generally, a number of protocols have changed during your career. We went from uh, a pap smear every year and a pelvic exam and a breast exam
But,
every year. And currently, as we have this conversation, how has that changed?
oh yeah. The current recommendation is every 5 years with negative HPV testing. But of course, nobody ever heard of HPV way back when. and
Right.
a test for it.
Right. And other conditions have changed during your career. I'll give an example of ectopic pregnancy. How during your career has that changed?
I was thinking about that earlier when I was going over this. I remember that way back when I was training, if you had a suspicion of somebody had an ectopic, they diagnosed you by putting you in the hospital, wait till your hematocrit started dropping, and then whisk you to the OR at whatever hour. Now it's,
Hmm.
a couple of ultrasounds and methotrexate,
Right.
but
And
for most of
so,
my career, it was the treatment was largely surgical. After a while,
yeah.
it became surgical via laparoscopy, but nowadays it's just methotrexate mostly. Because
Well,
you can
in
diagnose them so early. And of
early
course,
in your career, um, probably just as you were finishing your residency, the most sensitive pregnancy test would be about 200 units or so. It wouldn't be, and they were run in the lab, and they would take a day or so.
oh yeah, that's the
Um,
biggest innovation I think with the ectopics is that way back when, half the time they used to say 50% of ectopics will have a negative pregnancy test.
hmm.
And now it's all based on HCG level. That's one
Right,
thing that's really changed dramatically over the years is the tests are so sensitive. You know, people know they're pregnant before they miss their period.
right. Even the home pregnancy tests are 10 times more sensitive than the best tests at the in the late
Yeah,
70s. And so the diagnosis is a lot sooner. Also, there were procedures that we don't do that often today, such as cholecentesis. Did you use that at all in your practice?
I think I've seen it once or twice as a resident.
That was about it.
Yeah,
Okay. And also, it wasn't until later in your career, probably the early 90s, before vaginal ultrasound, transvaginal ultrasound was available. And so, even though you were using ultrasound early in your career,
yeah.
it was not nearly as sophisticated as it later became.
We thought grayscale was a vast
Right,
improvement. I mean, you had to really have an imagination to read the OB modes.
right,
But
right. They would,
now, especially with the vaginal probe, you can see tons of stuff.
right. I think in those days, people did not have office ultrasounds. The machines were
Right,
very large, and you were going to have trouble seeing a pregnancy probably before 8 weeks or so, somewhere in that range
right.
with the transabdominal ultrasound. And basically, ultrasound it was primarily an OB technology as opposed to using it for GYN. And you know, you were counting the number of babies, where the placenta was, and roughly how far along the pregnancy was. That was about as far as it went. So during our career, there's been an amazing change
Oh,
in the
big
way
time.
that technology's played out. Yeah. Um, so as far as other conditions go, anything else strike you as changing? Let's back up a little bit. You said earlier in your career, you were treating cancer of the ovary. And what have you seen occur during your career with regard to treatment of cancer of the ovary?
What have I what?
Have you seen in your career regarding the treatment of cancer of the ovary?
Well, it's all
How
changed
has that
now.
gone?
It
Yeah,
all goes to an oncologist. And, it's so sophisticated now, there's no way you could be a generalist and keep up with all you would have to know,
right,
to treat it. Look at
right.
Roland
And
Meyer.
yeah,
I mean,
well,
he was a thing, but you just can't keep up if you're going to do general OB.
no. And was there basically the role of chemotherapy has changed
Right,
significantly. I think early in your career, chemotherapy may not have made much of a dent. Today, the survival rates are
right,
much better.
right.
So that's another feature that has changed. And with regard to the management of a normal pregnancy. What was typical prenatal care like when you began?
Um, well, it was, every 2 weeks for the first trimesters, and then 2 weeks, and every 2 weeks, and then weekly in the end.
Yeah,
I think what's changed is the more routine use of ultrasound. I mean, when I started practice, there were a lot of patients that wouldn't have an ultrasound because they said, well, they don't know enough about the ultrasound and the sonics, and does that do any harm? But
right.
of course, that's all. I mean, now it's just routine.
And ultrasound needed a strict indication. Chances are you weren't going to be getting one in the first trimester.
Right,
Um, and the capacity of the ultrasound to tell what was going on was very limited
right.
in those days. As I said, where's the placenta? How many are in there? And
Right.
roughly when's the due date? Was
And the
about
other
it. They
thing I
weren't really
think that's changed with
anatomists.
time is the prenatal diagnosis of genetic disorders. I mean,
Hmm.
way back then it was an amniocentesis at 17 weeks, and
Right.
with a risk. And now they can test for a gazillion things.
Yep. Yep. So a lot of advances that way.
Yeah.
And with regard to the management of labor, has that changed much at all during your career? Were they always using monitors all the time, or were they
No, way back,
periodically
they were
switching?
always using them, but a lot of people wouldn't use them. A lot of people would only put up with intermittent monitoring, stuff like that. I
Hmm.
think that's what's changed in that regard mostly is the prostaglandins and cervical ripening techniques.
Hmm.
In way back when, I can remember as a resident having somebody that we would that had a death in utero, do a saline abortion, and sometimes talking about cul-de-sac, the uterus would rupture into the cul-de-sac because the young nullip's cervix was so resistant and hard they couldn't
Hmm.
dilate even with the saline. I mean, it didn't happen often, but it happened once or twice enough to stick out in my mind.
Sure. Yeah. Much more difficult. And in your early career, there wasn't the ready availability of an epidural for labor management. Is that correct?
There was no availability. Um, when I first came to town, as you know, we talked to Lit and Kirkendall and Maha. The style in those days was spinal low forceps.
Yeah.
And I think the first epidural that got done in Worcester was in the late 70s by one of the Dr. Dilip Rajadiksha on a patient of mine with peripartal cardiomyopathy. And it was given more for relieve the strain in her heart. And then it wasn't
Sure.
until Steve Cohen came to town
Uh-huh.
when he was doing OB that he said, I can't do this without epidurals. So, you know, then once, of course, they started, they really took on.
Sure. And also, I think the Lamaze movement was pretty established early in
It
your
was.
career. Is that
Yep,
correct?
that's
So
correct.
there were a lot of women who really were shunning medication and seeking to manage their labor themselves with the
Right.
training they get.
Yep.
So, so that came in quite a bit. And how long were people staying in the hospital after after normal vaginal delivery in those days?
3 days.
Yeah. And
Dr. Willett, when he was active, it was 10 days. Dangle on day one.
okay. And uh, the what was your early in your career? What was your cesarean section rate?
Um, it was pretty low. Um, St. P's, I think, in general, had one of the lowest ones in the state.
Mm-hmm.
Because for the first part of my career, quite a bit of it, I delivered vaginal breaches, which
Mm-hmm.
these days, that just adds to the section rate. What we weren't
Right.
doing way back when, though, was VBACs, which I think is a real positive step.
Yeah. Yeah. But you were probably under 15% in those
Yeah,
days.
yeah,
Somewhere in the 10 to 15% range probably
Right.
would describe.
Memory serves, I think about 14-ish.
Okay. And as far as doing instrumental vaginal deliveries, did you use forceps at all?
I did. I also did Worcester's first vacuum delivery.
Okay. When was
I
that?
don't know if you're interested in this for the archives. I got a nice email from a patient about a year ago that just happened to see that I was still in practice. She said, "Hi, my name is so and so. I just wanted to say that I was Worcester's first vacuum delivery, and the
Uh-huh.
product of that is now a senior in medical school."
Oh, okay.
Yeah,
Nice outcome.
yeah.
So what sort of, so you did forceps in those days. You have, was that a common thing or not so common?
It was pretty common.
You, yeah,
Well, as I said, when I got there, the style was 98% of people had spinal and low forceps. So a lot
yeah,
of people just
yeah,
expected that.
yeah.
But then I couldn't believe that nobody at Worcester had done vacuum extraction. So I, hounded the hospital administration to get one, and we finally got one. And then I would
So
use
when was
that.
that roughly?
Hmm?
When was that roughly?
Oh,
When?
gee, I'd say if I came in 76, I'm going to say we had the vacuum by 78.
Okay, a couple of years after you arrived. And what
Yeah.
sort of instrument was it compared to what they use today?
Oh, it's terrible. Remember the
Yeah,
Nadelson? It was a metal cup that took
right.
13 minutes to apply. You had to increase the pressure for 2 units or whatever. And the poor little
Yeah,
kid
yeah,
would have a little crown. I mean,
yeah,
it worked, but it was now the silicone and
right,
yeah.
right. A little better. And as far as obstetrics goes, I think, let's see, what else should we talk about there? We talked about the forceps. Um, we talked about ultrasound. Now, as I said early on in your career, ultrasound was not something done in the office. It was very limited in its capacity. It was not something routinely done in pregnancy, and
Right,
probably less than half of women who were pregnant had an ultrasound
right.
done. So, that is a significant change from the present
Yeah,
where people will commonly have a couple of ultrasounds done.
yeah. Now it's a standard of
During
care.
pregnancy. Yeah, yeah. And do you feel, so there have been a lot of changes. Are any of the changes things you feel have tremendously added value? Have there been some unanticipated downsides? What sort of thoughts do you have regarding that?
Well, I think more of the hysteroscopy has really made a big difference over the years. As
Yeah,
the less invasive approach as to you know, more invasive.
yeah, yeah. And as far as the routine screening that occurs during pregnancy, when you began your career, there was no genetic screening. There were, routine tests for anemia, syphilis, diabetes, that sort of thing. But
Right.
with regard to genetics,
There
there
was
was nothing
nothing.
unless there was something very unusual in the history or the like.
Right. Well, the mother was very concerned. In those days, it wasn't unusual to have, at least with Dr. Luck's practice, have somebody come in and say, "Well, I'm either menopausal or you know what." And sometimes it would be you know what.
Yeah, right. Right, and so we would routinely offer an amniocentesis to a woman who was going to be over 35
Right.
when she gave
Yeah.
birth. So that was a common thing. But even
And then
then, not every woman would take you up on that offer.
right. Well, you had to tell them there was a risk.
Yeah,
A lot
right,
of people weren't willing to take that. And then, of course, the big next thing that came around was the alpha fetoprotein. That
right,
helped.
right. And so that we went from there, and then after the only tool was an amniocentesis with a growing of cells that were obtained in the amniocentesis that would take 3 weeks or so
Right.
before you get an answer. So you'd have to wait till 16, 17 weeks or so to do the amniocentesis,
And then 2 or 3
and then
more
you'd
for the
have to wait.
results.
Right, and it would, so that was quite a difference from today,
Mm,
where results are much more readily available, and where even screening tests using maternal blood are offered to mothers.
right.
So again, quite a big difference at all with regard to that. And with regard to, you know, group practice and the like, you've spent your whole career in private practice.
Right.
Uh, what are your thoughts regarding the pros and cons of that?
I have no regrets. You know, the big thing about joining a group is you come in as just an associate. There's no out-of-pocket costs. You just come in and start earning a salary from day one. Um, but the private practice has worked out for me. We've grown over the years, and then about 7 years ago, I merged with another practice, and because I wasn't doing obstetrics anymore, and I wasn't interested in running a business anymore, and now I'm just an employee, and I do my thing, and
Yep.
don't have to worry
And
about doing enough.
did you feel, now you made a transition into an established practice. Did you receive any sort of training during your residency that prepared you for the business end of practice?
No,
And did Dr. Willett help you with that? Is that something you sort of got
those
trained in as
guys in
well?
those days, they weren't that good businessmen anyway. They just,
Okay.
but of course, they just, 99% of people had Blue Cross Blue Shield, and you had to accept what they paid you anyway.
Yeah. Were there elements regarding the billing that you picked up during your career that you learned how to run a business and deal with hiring and buying equipment and making those kinds of decisions? Were you
Oh yeah,
involved in that?
we've moved several times, and as the practice grew, um, I hired billers, um, and of course then medical billing became a specialty unto itself.
Right.
Way back when, everybody just won it and said, okay, well that's the way you do it. But yeah, I had to hire people, and then computers came in. We didn't have computers when we first started.
And did you learn that, or did you were able to delegate that to someone in your office?
I sort of
Did you
learned it.
learn the? Yep. Okay. And what were the first things you learned to do in medicine with regard to a computer?
Um, gee. Well, billing was probably the first thing,
Sure.
because we didn't, the medical record didn't come for years and years after that.
Right.
And so when it started, it was billing, scheduling, stuff like that.
And all of this happened before the internet.
Yeah.
So even things like PubMed and like weren't necessarily available to you at that time.
Like what?
So PubMed and things like that that
No,
are
no.
web based were not available. So you were basically doing your best to keep up with things. And how did you learn what billing program to buy? Where did you pick that up? How did you go through the process of figuring it out?
I forget the first one we had, but it was a vendor. We interviewed a couple of people, and it was that was even before computers. It was a ledger-based system where patients
Yeah,
all had cards and,
yeah.
physical things that you'd write out a bill every month and stuff like that. And then we computerized, and then that became the billing system, and everything got sort of done automatically.
Hmm. Hmm. And how did the advent of managed care, where rather than simply paying a bill, the insurance companies began developing standards and various pre-authorization protocols. Did that
Right.
affect you at all during your practice?
Well, then you had other people competing for your patients.
Yeah,
If, for instance, as you know, Fallon Clinic has been very good to me for my whole career, but, you know, we had a deal where they said anybody that's your patient will pay for their, yearly checkups and stuff like that. But of course, not all plans do that.
Right.
So it's a case where the husband signs up for the cheapest thing he can get at work, doesn't even
Yeah.
ask if his wife's obstetrician is in it.
Yeah.
Then she finds out you're not. And then, either you go or the
Yeah.
husband goes.
Yeah. Yeah. So there was that disruption there, and patients would come and go as a result of that. You're right.
Yeah.
Um, and government regulations, did you feel those changes affected your practice at all?
I can't think of how they had a big impact on it, no, except Medicare is essentially government regulations, just another form of insurance that you have to deal with.
Yeah. All right. And the issue of abortion. Roe v. Wade was during your medical school,
Yeah, 76.
and you were trained at Georgetown, both in medical school and in residency.
Right,
You opened your practice at a Catholic hospital, which
right.
you spent your career at. So how did you deal with the question of elective termination of pregnancy?
Well, despite the fact practice at a Catholic hospital, I believe it's a right to a woman's choice, so I would counsel them the
Yeah.
best I could in terms of, whether it's a abortion or miscarriage, it's a pregnancy loss, and then it would be up to the patient. If they decided on an abortion, I'd usually send them to Planned Parenthood. Or if they had
Okay.
medical problems, there was a practice in Chestnut Hill that was, I forget the name of it because they haven't used it for years. That, if they had an 18-week problem or a 14-week,
Yeah.
something that Planned Parenthood couldn't handle.
Right. Okay. And okay, I guess the other piece here is there's a lot of discussion regarding burnout in the profession of medicine.
Yeah,
Do you have any thoughts about that? You've had a career that spanned a long period of time.
46
You've
years.
and you've basically been in an intense specialty and in private practice, which generally is a little more consumes a little more of your time
Yeah.
than being in other practice modalities would. Do you have any thoughts regarding burnout? Have you felt it yourself? Do you have any advice for, the career life balance for people?
I'm happy where I am right now, Dale. I uh,
Yeah.
I sort of look at the years I spent doing all that work in private practice. Now I'm reaping the benefits. I just work a
Hmm.
couple of days a week. I see, new patients and all sorts of patients, but 80% of them are people I've known for 30 years.
Yeah.
Nobody calls me at 4 o'clock in the morning.
Hmm.
Uh, so I sort of look forward to going to work. To me, it's nice compared to how I was
Okay.
working 10 years ago.
So, what do you have any observations regarding those who are experiencing burnout in medicine? Do you have any idea as to why they're different than you?
I think it's I think something has to do with the kind of practice I had. And I just didn't,
Hmm.
work up till the end and then say, okay, I've had it. I can't do this anymore. I have an option.
Right.
I say, okay, I don't have to work 60 hours a week.
Yeah.
Whereas I think a lot of people, it's all or nothing, especially HMO employees and,
Hmm.
in big groups because they're being told, okay, you've got to hit your quota, you've got to make the numbers. And um, I can see why something like that would burn out. My own PCP found he was doing. He used to say, when I go into the office, I have to get up at 5:30 in the morning because everybody that has a throat culture in rural Georgia, someplace, it crosses my desk. So it takes me two and a
Uh-huh.
half hours to review all my stuff before I can even walk into work. And he said, I just
Hmm.
can't take it anymore. But and he said, and I can't go to part-time because they'll all get me for abandonment. So now what he does, he's left his practice. Now he works a couple of days in the week helping the other people in his office. And he said, this is great. I just,
Yeah.
work a couple of days. And I think
And
a lot of people don't have that option. I think that contributes to the burnout.
yeah. How about family life? Do you think your family life was different from other people's? Do you feel anything about that?
I don't really think so. I mean, we did a lot of the family over the years. One of the advantages of being in private practice is that I wasn't punching a time clock. So if somebody had a baseball game and it was at 4 o'clock, but quitting time was 5, I could say, okay, adjust my schedule. I want to be at the game. So I mean, I could use
Right.
that. That worked as much for me as other times it worked against me.
Yeah. Okay. Well, it sounds like, one of the things I'm hearing from you, you worked very hard, but I think the burnout value of work is tied not just to how hard you work, but also to whether the tasks you're doing are your choice, or whether you
Right.
feel that something is being imposed on you.
Yeah. Like
And
my internist said,
yeah,
I didn't
yeah,
sign up to get up and go over computer data for 2 hours every day before work.
right, right. And so the burden of something that you're doing in response to a demand as opposed to a choice, I think is
Yeah.
maybe behind some of this. Um, any other thoughts regarding your career that you'd like to mention?
Glad I did what I did. I got no regrets.
Yeah,
Um,
yeah,
worked out okay for me. Family worked out good.